please join me in welcoming Dr. Sutherland. Thank you.
Well, thank you very much. I would like to thank CHSRF for providing me the opportunity to work on this paper, because I feel that there's been so much interest in this area over the last few years, and a number of us have been somewhat toiling away, probably working on the mechanics under the hood for methods such as what I'm going to be talking about today for many years. In fact, I've been working in the area for about 10 years or so. So it's nice to see that finally people are starting to pay attention and get the discussions moving. So I'm very glad that people are interested, and I'm glad that everyone's here, and I'm happy to field questions afterwards, in addition to emails. So I'll just get us moving here. We're moving away from there's some sort of a sense of an evaluation of global budgets, and what are the limitations about global budgets. Hospitals have been predominantly funded this way for decades in Canada, as opposed to many other countries where they've moved to experiment with other kind of methods. So there was some sense in the paper to evaluate, well, what isn't working with global budgets, and what are some of the stakeholders' key concerns regarding the limitations of global budgets. And this is not just from Canada, but part of the literature synthesis that I did on behalf of the paper. But a lot of people were complaining with regards to the issues of transparency and fairness with global budgets, in that it was hard to articulate whether or not hospitals were serving the patients for the same amount of money that the other hospitals were, and how they were able to influence decisions in terms of how much or how their base was affected. Global budgets have also been perceived to perpetuate historical inefficiencies and cultural differences between hospitals as well too, because there was some sense of entitlement with, well, we did what we did last year, we're going to do the same next year, and we know we're going to get funded for the same amount of activity and for the same type of culture and activity, so why change? Global budgets have also been associated with long wait times, and whether or not it is the right tool and is associated with global budgets I think is still a bit of an open question, but people are complaining that global budgets are affecting wait times, and we're going to come back to that further in the talk. Also, global budgets have been associated with unexplained variation in cost and utilization in many different settings, and this is true in a regional and in a hospital basis, that hospital utilization and costs vary considerably across Canada, and they're looking at global budgets as being a significant contributor to that unexplainable variation. Furthermore, in global budgets, there are the limitations that it doesn't provide a lot of incentive for hospitals to innovate. There's no rewards at the end if they're able to reduce length of stays or find efficiencies or purchase new equipment. There's no reward for taking a risk on new kinds of care because they know they'll get funded at the same level with some adjustment. There's also been some comments with regards to linking global budgets to emergency department bottlenecks and the lack of acute care beds. So this is an open question as well too. And that is certainly linked to the next bullet there that I have, which is the alternative level of care, which is a project that's ongoing right now, in that does global budgeting affect or positively influence the number of alternative level of care beds right now. Because right now, if you're going to shorten your length of stays to try to increase your volume of hospital care, you're going to be affecting or being influenced by the alternative level of care days in there too. And much like the reward for innovation, there's no incentive to invest in higher quality or procedures or innovations that may affect or improve patient quality. So these are sort of a list of the complaints that I was able to find with regards to global budgets. So where are we going? It seems that many provinces are considering activity-based funding, which is the mechanism by which hospitals are reimbursed or funded for the type of activity they do and for the complexity and volume of patients that they treat. Now, this is somewhat of an exhaustive list of different countries' rationales and reasons for moving towards activity-based funding. Now, certainly not all of these apply in Canada, but I think it is interesting to see that as you examine different countries' rationales for moving towards some basis for activity-based funding, why they did so and what they were hoping to achieve with that. And probably the most common reason for moving towards activity-based funding was to stimulate hospital productivity. And that comes to the second point is activity-based funding's effect on or creating incentives for reducing hospital length of stay. So stimulating productivity in terms of increasing the volume of hospital care. Now, as you increase the volume of hospital care, many countries have cited this as affecting waiting lists. So a number of countries, including our own, waiting lists are a huge concern. Is activity-based funding able to improve the volume of hospital or increase the volume of hospital care, commensurately decrease or reduce the hospital wait times? Now, in a number of countries, they certainly cite increased competition between hospitals to try and get patients in the door to attract that kind of revenue. I think that it would be much more difficult to find that case in Canada, except in some very heavy urbanized areas in Canada, because we have a lot of geographic dispersity, which makes this argument certainly much more tenuous than it is right now. A number of countries have also implemented activity-based funding schemes for trying to monitor or to encourage the monitoring and benchmarking of hospital activity. Now, this is certainly the case in Canada, wherein we have had some form of case mix system for well over 20 years, and we have used that predominantly through CMG Plus and its precursor CMG for monitoring and benchmarking, but we've been limited to that. Some countries also use activity-based funding as a basis for reducing hospital capacity in terms of the number of beds. And this was the experience down in the state of Victoria, Australia, when they implemented activity-based funding about a decade and a half ago. They felt they had excess capacity and wanted to reduce that capacity. Now, this was also the case in Germany, where they also felt that they had a huge surplus of beds and used activity-based funding as a mechanism to try to articulate where the excess capacity was and let the market forces decide how many beds they needed. Second and last point regarding activity-based funding is with regard to providing additional choice for patients in terms of where they seek the care. This, I believe, is a much more difficult argument in Canada as well, too, because patients predominantly go to the hospitals where their physicians have admitting privileges, where in other countries they may have a lot more flexibility. And this is certainly articulated in England's case of the implementation of activity-based funding, whereby they feel that patient choice in terms of where they receive their hospital care is much more important. Now, lastly, there's initiatives in several countries with regards to using activity-based funding to harmonize public and private systems. Now, this certainly is not an issue in Canada at the current time. However, there are a number of countries that run parallel systems, such as Australia, England, Ireland, and a few other of the Nordic countries, whereby they're trying to articulate the differences between what the public system can or should be paying for care and compare that to the private providers. So that's somewhat of an exhaustive list that I could find regarding my synthesis review. Now, I have to remember, as I start to go through the slides, I do have fairly tight times, but I'm very interested and very passionate about this, and I can talk for hours, so I've tried to distill it into just a few slides here to highlight the points. I think it is worth pointing out, and of course this is why you're here, I think, that there is a lot of activity-based funding activity currently occurring in Canada. We currently have seen announced or implementations of activity-based funding in British Columbia, Alberta, and Ontario. Furthermore, there are other provinces that are purchasing additional surgical volume on an incremental basis, which is really a form of activity-based funding. And this is not an exhaustive list, although I do cite Saskatchewan and Newfoundland. We heard that last week. Activity-based funding does have quite a high number of very high-profile supporters, including a lot of the medical associations and hospital associations. With regard to medical associations, it's not a surprise that that sector of healthcare is quite supportive of activity-based funding. This is a policy instrument whose primary objective is to increase the volume of hospital care. So we get a lot of support in that area. Now, the support is not universal because some stakeholders, such as the Canadian Doctors for Medicare, are very anxious about some of the unintended consequences of the implementation of activity-based funding. And I'll cite some of those concerns a little bit later. Activity-based funding has certainly become the international norm with which to fund hospitals in most of the industrialized worlds. In fact, it was very hard to find other examples whereby global budgets were still used. I think Canada essentially was the only place that, Canada and Greece were the only places that I could find that global budgets are still in use. And most industrialized countries now have moved to some form of either a mix of global budgets plus activity-based funding, or predominantly a heavier mix of activity-based funding. Now, what are the major motivating factors that we've heard in Canada with regard to the rationale for moving towards activity-based funding? Well, the one that we hear the most is improving the timeliness of access. So access, the dimension of access having to do with timeliness, in that activity-based funding as a necessary component or an important component to increasing hospital volume increasing that volume will improve the access to hospital-based care. And this is certainly true with a lot of the incremental funding programs designed to improve access for procedures that have currently very long wait times. Another important issue is with regard to it is being viewed as a way to afford some mechanism of transparency in hospital funding. With global budgets, the mechanism tends to be a bit of a black box, subject to politicking and other forces. However, activity-based funding that's transparent can certainly open up the discussion and limit the risk with regard to political influence in the hospital funding mechanism, because it's a much more transparent system. And a lot of stakeholders are also viewing this as an opportunity to increase the value of healthcare, hospital-based healthcare. Now, I've certainly listed some of the limitations of global funding, but I think it is very fair to point out that activity-based funding has its own whole host of issues that are important to recognize. However, first I'll point out that the activity-based funding is primarily used to create financial incentives to increase volume. So the hospitals, the providers in this case, have the incentive to improve efficiency, generally used through reductions in length of stay to reduce the cost of their patients, and then they'll have the ability to retain those surpluses to redirect to different areas of patient care. So this is a very powerful incentive that hospitals would have. The political incentives are also very strong as well too. It minimizes hospitals' ability to claim unfair funding levels, and it reduces the risk of hospitals complaining to the minister or the ADM with regards to the level at which they're funded. Fortunately, we also have decades of experience from which to be able to identify the limitations of activity-based funding. And I think provinces that are implementing activity-based funding are certainly drawing on the literature to be able to try to mitigate some of the issues that they have right now. So as you pay on an episodic basis, there's no incentive to provide coordinated care across the spectrum. And this has happened that in certain jurisdictions, certain countries, what you see is a very high degree of fragmentation across the continuum of care because you're paying for volume in the different sectors. I think it's very important to note that. There's also the tendency, and this is not just occurring in the United States, to over-provide very profitable services. Now, we've seen in literature very high-profile cases of orthopedic services or diagnostic imaging, as well as some other ophthalmologic services. These have been identified as high-margin areas whereby the cost of production is a lot lower than the payment rates, so they have resulted in over-provision of services. It also, and Canada is not immune to this, opens up the possibility to upcoding, and that is to document comorbidities that are not influential in terms of affecting care or the cost of providing that care. So what's the evidence with regard to activity-based funding? You know, we can draw from over 20 countries' experience to be able to cite this. And I think that there's fairly good evidence with regards to its tendency to result in shorter lengths of stays. This does happen. It does also, or is also highly associated with increasing the volume of hospital care. That is, the number of patients who have episodes of hospital care increases. It also tends to increase the volume or increase the amount spent on hospital care associated with providing more care. So in some jurisdictions, they have instituted caps to try to limit the growth, and I'll come back to that a little bit later. One of the concerns is when activity-based funding systems have been implemented across other countries, that there is the fear that hospital quality will decline. There's no evidence in the literature to date associating with decline of hospital quality to implementation of activity-based funding. With regards to efficiency, currently what we're seeing is very mixed results. So whereby the cost per patient is not declining with the implementation of activity-based funding. So spending increases with higher volume, but there's higher volume. So the efficiency results have been mixed so far in countries that have implemented broad-based activity-based funding systems. Other significant limitations that people have identified but are still largely open areas have to do with geographic access. And I'll come back and spend some time about that, but it's certainly a significant concern here in Canada where we have far-flung nodes of population, whereby geographic access is certainly a limitation or a concern to think about as activity-based funding is implemented. There's also the issue of equity of access. For instance, if activity-based funding induces some consolidation of clinical services in some urban areas, what may happen is that it may reduce the access to clinical care in some of these outlying areas. So the equity of access is such that, it's been demonstrated that poorer people travel less to seek their hospital care. So there is the issue of equity of access to consider as activity-based funding is implemented. With regards to areas that there is no evidence, I highlight those here, and it proves that there's no evidence associating evidence-based care to activity-based funding. So we don't have any evidence saying that it improves or decreases evidence-based care. There's also no relationship between activity-based funding and the provision of effective or appropriate care. And there's not a lot of evidence currently with regard to activity-based funding programs designed to increase hospital volume and their effects on other sectors of care, such as long-term care and nursing home care. And certainly that's an area that's now being looked at. Nonetheless, these limitations are certainly clearly apparent also in global budgeting. So these aren't new, even though I do list them as minuses or things to think about. Now, I've had the fortunate position of being able to travel across Canada and internationally to hear what some of the primary concerns with regard to activity-based funding are, and I list 6 of them here. First off, we have health human resource concerns. So as this policy is implemented, what it tends to do is decrease the length of stays in hospitals. So as you decrease your length of stay, you're chopping off the less acute portion of the hospitalization. So that means that the patients hospitalized still have a higher average acuity. So does this mean that you're going to have a richer staff mix? These are really important questions. So is there going to be an increased demand for nursing care? So also there are concerns with regards to wait times and how wait times may increase or decrease with regard to the relative profitability of different kinds of procedures. For example, procedures that are very profitable may be fast-tracked to provide more care, whereas those that are unprofitable or less profitable observe increases in wait times. I also already noted the issues with regards to people having concerns regarding the quality unintended effect. However, there's no evidence on that basis right now. Also, ministries of health and government certainly articulate that they are very concerned with regards to the financial health of hospitals with implementation of activity-based funding. That is, that they are very concerned with regard to the financial state of hospitals as this policy is implemented, and that they are nervous that some hospitals would experience very large deficits. Now, in some countries, this has been mitigated with the commensurate introduction of stop-loss measures or redlining, such that the limits are decreased to, say, 1 or 2% on the downside. Also, a concern that's been articulated is the issue of patient satisfaction. So as length of stays are decreased, there is some concern that patients may not only have less high-quality hospitalizations, but they may articulate that in terms of their satisfaction with the hospital care. However, the experience is, and I could only find one paper in this regard, is that patients were predominantly very happy with the introduction of activity-based funding, and that is that they perceived that their wait times decreased, which was somewhat unexpected to me because they probably didn't understand the funding mechanism, but they did understand the fact that they were waiting less time to have their hospital care. Now, what is activity-based funding? There are two streams or two elements, core elements to activity-based funding. In the first, the payer, which is usually a Ministry of Health, or it could be regions, or it could be countries, I'll just define it as the provider or the payer, defines the product groups that hospitals produce in terms of discrete groups. So in Canada, we have CMG+. In the United States, the Medicare payer has DRGs, and most other countries have designed their own. Now, they design their own to reflect the payment policy that they want to impose with the activity-based funding policies. However, at a very high level, the more narrow you define your product groups, the more precisely you are describing your costs. So so you are blunting your incentives for innovation and improving volume for profitable services and that mechanisms. The broader you define your groups, and the payment rate is set at the average, well, what you're doing is you're opening up the possibility the hospitals will be able to risk select there, and that they'll be able to either find the procedures within larger groups that are more profitable, or they'll be able to find the patients that are the most profitable in those groups, and will be able to behave accordingly. Most product groups are case mix systems generally tend to have between 500 to 1,400 groups, and we're seeing this in most countries. However, in Canada, what we have is different permutations of product groups with special adjustments for the number of high-cost procedures, trips to the operating rooms, many age groups, and comorbidity levels as well too. So this leads us into a different situation whereby we have over 10,000 product groups from hospitals at the current state, which is certainly well above the norm. And it certainly lends itself to be described as a very highly complex cost-based reimbursement system in its current state. Now, once you define what you're going to define what the hospital produces, the next step is to assign a payment amount to that. Now, how do you define what your payment amounts varies according to the different countries and what their objectives are. So I can describe that in Ontario and Alberta and British Columbia, they have patient-level costing initiatives in place whereby they attribute the intermediate products of the hospital to the patient and have set methods for allocating overhead down to the patient so they know quite precisely the costs of the patients. Some of the issues with regard to the patient-level costing systems are that it's not standardized across provinces, so there are variances between the different provinces or settings that implemented activity-based funding. And there's only one province that actually has a provincial standard, and that's Ontario, which has the largest activity-based funding program currently to date. However, there are other mechanisms for deriving prices for product groups. For example, in Medicare, what they do is they use the charge data that hospitals use, and they transform the charge data into a cost, and they use that to set relative prices. Australia takes a very different approach whereby they feel they have discrepancies between the cost of production and the payment amount. They conduct micro-costing studies on the clinical activity to derive a more precise estimate of the cost in those groups. In the UK, they take a very different approach whereby they use all hospitals' financial data and use a step-down accounting method to try to attribute patient-level costs. However, this can be a very complicated process, and it sort of opens up the question about, well, what's in the patient-level costs? Now, as people think about using the resource intensity weights that CIHI uses, you have to think about the source data that Ontario and Alberta generate. How clean does it cut out the research costs? How clean does it cut out the teaching costs? Are all the capital costs in there? Are the salaried physicians in there? So there's all a very complicated set of assumptions with regards to what components are in and what are you going to be paying for. So, and I think this slide here is primarily the most important slide of the presentation. And this is the biggest risk of activity-based funding. And it highlights the issue of not getting the price right. What happens? Activity-based funding can be a very expensive policy experiment if you misprice the services you want to use, whereby you will see very steep increases in the highest margin activities, and you'll see a lot less activity in the very low margin or unprofitable activities. And this, although I highlight with a few papers in the United States, is not only in the United States phenomena. This occurs in other settings, and they have difficulty setting these prices. So that's why I come back to the fact that setting your price of your products group is a very critical component to an activity-based funding scheme. I'd also like to point out further on that method that there are a lot of ways for attributing costs to patients. And I have here a few different citations that say, well, look, this is the way we did it, and this is the results that we have. For example, one of the papers here is citing a top-down approach as opposed to a bottom-up approach, and they find significant differences in the patient-level cost. And this is certainly a cost-effectiveness study whereby they're using the patient-level cost, but the same would be it would be the same for an activity-based funding scheme price as well. So then I want to sort of back it out a little bit and say, well, do we have the data and information systems and reliable data to be able to credibly execute activity-based funding within the Canadian provinces right now? We have to ask ourselves whether or not we have the correct level of detail of clinical data. And it's not only the level of detail, but also whether or not it is precise and is available timely, in a very timely way. In many provincial ministries that I've visited, I do hear that the provincial data is not accessible to the healthcare managers of the system in a very timely manner. They're either waiting for the hospitals to abstract the data, to send it to CIHI, to send it to their IT department, to send it up to them to manage it, which is a process that can take up to a year in several provinces. So the timeliness of access to the clinical data becomes much more important than it is right now. Then the financial data is certainly very important too. And what we see now is that the MIS, which is a national standard, however, has a lot of assumptions built into it with regard to how different department costs are allocated into different departments. And this becomes a much more critical area as you use activity-based funding, because as you shift costs into non-activity-based funding areas, you can certainly look more or less efficient relative to that. And I talked about the patient-level costing and its variability in accuracy and completeness and comprehensiveness and availability across the setting. However, I do think that in some provinces, they certainly meet all the criteria to be able to credibly execute activity-based funding. In a number of provinces, though, where they don't have great data to the clinical data or to the financial data or to patient-level costing, I think they're certainly at risk for mispricing the clinical services using activity-based funding. And what are some of the key implementation challenges around activity-based funding? Well, certainly deciding what the volume of activity that you want hospitals to conduct each year is certainly an important determination. And setting up service contracts with the hospitals to provide that level or set product goods is an argument that doesn't happen now with global budgets as much as it would. Also, do you want to have hard caps on your spending with activity-based funding, in which you're certainly blunting the economic incentives to change hospitals' behavior? Or do you want to have something like a semi-permeable cap, whereby if they hit certain targets for increased volume of care, I'm getting to 2 minutes and I still have a long ways to go. So I'll try and get a little bit faster here. Certainly, what's also been needed as a long-term commitment to governments to implementing activity-based funding in order to induce behavioral changes. So that if activity-based funding initiatives are viewed as one-offs, or by it's a 2 or 3 year program, you generally do not see the behavioral changes in the hospitals. So a long-term commitment to change is certainly needed. What are some of the risks of implementing activity-based funding? And these are preparing for changes within hospitals. You will see your case mix, your volumes change, and be prepared to understand how this is changing as it occurs. Also, be prepared for differences in hospital financial performance. whereby you might have had hospitals having surpluses, you may see them turning into the red. The converse is also true. Those in the red maybe actually have been very efficient performers and may turn into surpluses in those hospitals. Lastly, management, and I raised this in the paper, the management in hospitals in countries that have implemented activity-based funding is such that you do see quite a high turnover in your management hospitals, commensurate with the implementation of activity-based funding in the first couple of years. And that is predominantly because the job has changed for them with regard to just being expenditure managers into now being revenue and expenditure managers. Also prepare for change in other sectors of care. If activity-based funding is just rolled out in the acute care sector, we're going to see higher volumes of care and demand for post-acute care. So long-term care beds, nursing home, and home care. We should be prepared to understand the impacts on these downstream sectors of care. And pricing, as I mentioned, is also a very critical component as well too, in that you will see increases in volume of the most profitable patients. In some of the provinces, this is a risk because it's only the hospitals which know what their marginal costs are, or even what their average costs are. But if the provincial or the price-setting organization doesn't have a good sense of how to set the prices, they'll just see spikes in activity in those activities. So what are some of the most important success factors for hospital funding reform? I would say vision and leadership, whereby people are able to push a sometimes not always popular position with regard to hospital funding reform, because usually there are winners and there are some losers, and it requires leadership to make changes. There's also political risk with regard to activity-based funding, in that some communities, notably those that are going to be affected either geographically or with regards to equity, they're not going to be happy with regards to activity-based funding program. So there are political risks that certainly should be considered as these policies are implemented. We also don't have a good sense or a good understanding of how these policies might be affected by natural geographic monopolies that we have in Canada too. For instance, in medium-sized towns, we certainly don't want the hospitals to go out of business. So does that affect their desire to achieve prices and understanding the relationship between the geographic monopolies and price setting? I also think that there are some considerations with regards to the applicability of something like activity-based funding in sparsely populated provinces, whereby it would be very difficult to achieve or desirable to achieve significant changes in hospital volume or efficiency. And also there's certainly a lot of risk with regards to understanding the supply and the demand for post-acute hospital services. I just want to say that it's also important, if activity-based funding initiatives are implemented, for them to be not only implemented, but for them to be credible on an ongoing basis. And one of the important aspects of being credible over the long term is to make sure that your data and information systems remain viable. So data quality surveillance becomes a very important aspect of this. And currently, I'm not aware of provinces that have mechanism for penalizing hospitals that engage in upcoding practices. So a mechanism for surveilling the activity data and for auditing clinical charts becomes very important as you implement activity-based funding and how that moves ahead. And who's responsible for the poor quality data? Is the abstractor, the hospital manager, or is it CIHI, which accepts the data into the discharge abstract database? So there's an attribution at different levels of responsibilities that I think have to be worked through with activity-based funding. Quality access, and the access has to do with timeliness, it has to do with geographic access, and it has to do with equity access. These need continuous attention because activity levels will change across the spectrum of patient types. International partners certainly have provided a lot of feedback with regard to activity-based funding, and I cite this from Personal Communications plus reviewing the literature. And then activity-based funding should be viewed as only one tool in the toolkit with regards to hospital funding. There are other ways as well, and it would be quite risky to move to a full activity-based funding mechanism. Some partners also describe that it's important to remove some important components from activity-based funding schemes. And that includes the capital costs for big capital projects, teaching, rural allowances, and emergency departments. get a lot of advice to make sure that they stay outside the scheme. Also, a lot of countries experience that it's very hard to set the price, in that understanding the difference between the cost of production and what you're willing to pay for and get the balance in terms of the volume of activity is very hard to do. Do you also want to pay for the best practice price, which might be much higher or much lower? Or do you want to set a price at the fair and achievable target, which might be the 25th percentile? Or would you want to set it at the average cost? There's also notably a few patient populations for whom setting the price is notoriously difficult, and I cite a few examples there. That includes the mental health population, pediatrics, and palliative care, very difficult to set prices for. And I'll come quickly to the end here. I think what we're seeing is some sort of consensus across the Nordic countries whereby they have the health systems most closely aligned with our own, and that they're turning towards a blend of a global budgeting and activity-based funding for funding their hospitals. And that level tends to be at a mix with regards to the proportion of fixed and variable costs in hospitals, such that the variable component is funded on an activity-based funding scheme, and that tends to be around 40%. I also think that it needs a long-term commitment from either the ministries of health or governments for them to induce the behavioral changes that they want to see in the hospitals with a phased implementation. It can't be full on right away. It has to be a phased implementation that's clearly articulated and described to the important stakeholders. And it's also important to note that spending increases are not equal to improvements in health. So you want to induce the increases in volume where you feel it will do the most good. And I know that some people in the room here, this is their raison d'etre, and this is really important to consider with activity-based funding. It's also difficult to make adjustments to activity-based funding for understanding the drivers in terms of growth, demand, natural demand, and for policy adjustments such as for socioeconomic status. I also say that payments shouldn't be on the average. You probably want to move something closer to the margin or something that's fair and achievable. I also caution people not to use CMG Plus for activity-based funding schemes because it too closely approximates a cost-based reimbursement scheme. I'm sort of out of time, but I was going to contextualize this in terms of other initiatives occurring in the environment with regards to trying to induce behaviors in activity-based funding. But the most common among them is the pay-for-performance that we're seeing in a number of provinces, notably, and Les has some experience, the pay-for-performance to increase the timeliness in emergency departments. However, there's also a lot of work occurring in the bundled payments, and you'll see a lot in the policy journals with regards to accountable care organizations. And I'd be happy to address that offline. So at that time, thank you very much. I'd like to say that it's a pleasure to have been able to participate in writing the paper and the documentation. I'm sure many people will find it quite helpful as they grapple with some of the policy and technical issues with activity-based funding and different payment schemes over the next few years. And I look forward to knowing those of you who I don't know yet, though I know that there are many of my friends in the room. So thank you.